In this video, you will see a discussion between the geriatric physician and the patient's niece, Ashley Smith. Please notice the ability of the geriatrician to ask relatively open-ended questions to try to assess the niece's understanding and awareness and concerns, and to then address them. Please also notice if the geriatrician reaffirms or acknowledges the challenges that the niece is facing and provides emotional support for the decisions that she needs to make, as well as the use of eye contact, reflective pausing, reflective listening, and confirming understanding of what was discussed. Thank you. Hi, are you Ms. Smith?
Yes, Ms. Smith. Ashley's fine.
Hi, I'm Dr. Paula Lester. Thank you so much for coming today. Thank you for coming so we could speak about your aunt. I wanted to find out first, what have the other doctors told you about her condition?
Oh, well, basically at this point, my aunt's had advanced dementia for a while now, and it's been a very slow process. And the hip didn't help, so doctors have been advising us on that. The latest doctor said that she needs a feeding tube because she's not eating as much as she should or normally would. She's, Ruth always said that she really enjoys food, and as far as I'm aware, she still does, but she's not taking in any of it. So the doctor said we should look at getting a tube for her to eat with.
Okay. Is a feeding tube anything that she ever spoke with you about, or this is just what you had heard from the other doctors?
Just from the other doctors, yeah.
Okay. Okay, great. Well, I'm one of the geriatric doctors in the hospital, and they asked me here in part to talk to you about the feeding tube and what it can and can't do for her.
Right.
So what are you hoping that a feeding tube would do for her?
I want her to eat. I mean, I'm very worried if she's not taking in food. I want to make sure that she's healthy, she's taking nutrition in.
Okay. Right. It's very natural to kind of want people to eat. Like, we all eat, and that's part of staying alive and being healthy. But not eating at the end of life is actually a natural part of that time in life.
I want her to starve.
Right. That is
important.
Absolutely.
Yeah.
That's very appropriate and loving, and it's natural. We all eat, and eating is what keeps us going.
Yeah.
The challenge is when the body eats less, or not as much as we think it should, and how do we fix that, and why did it happen? For some people, they can't eat because they've had a stroke or there's surgery to the neck. And for those people, a feeding tube can make sense because they anatomically can't eat, and they can be supported with an artificial nutrition in the stomach.
Right.
For some people, the feeding tube doesn't solve the underlying problem. Okay. And unfortunately, that's the category that your aunt is in. Part of the progression of advanced dementia is the natural progression is people eventually stop walking, stop talking, and stop eating. And the amount of food that people need at that stage of life is actually very, very small. They're not moving around that much, they're not even thinking that much, they're not doing that much. So they don't need to eat the same quantities that we do or that they did, even a year earlier. Right. But it is the natural progression that people will stop eating as part of the dementia. In your aunt's case, it's a little bit tricky because she just broke her hip. Yeah. So now she broke her hip, she got confused from all of that, she's not sure about her environment, and so hopefully those things can get better. But a feeding tube won't work in her case to make her live longer, to improve her quality of life. I don't know, did anyone speak to you about any concerns about her swallowing in particular?
The pathologist said that the tube might be really helpful in case she brings food to prevent it from getting the lungs and getting pneumonia. Okay. So that might be a useful medical addition to help her eat the food would be the tube to prevent that.
Right. So you were under the impression that one, it would give her the nutrition that she needs, and two, it would prevent her from aspirating, which is food going into the wrong pipe, as they say, going into her lungs. So, so those things kind of logically make sense, but we have a lot of research and experience in patients similar to your aunt, and what we found is that the feeding tube does not prevent aspiration or the food going into the lungs. If anything, actually, the number one complication of an artificial feeding through a tube in the stomach is aspiration, is food going in. And the reason is a few reasons. One is you're now putting food into the stomach in quantities that you decide instead of, or the doctor decides, or the dietitian decides, instead of the patient deciding if they're hungry or not. So one, you're putting in the amounts that you feel as opposed to the body taking what it can handle. Two is people still belch and burp and have reflux, and the food can come up and go down into the wrong pipe. And another issue is that people still make saliva. So even if you never ate anything, if you have saliva in your mouth and you can't swallow it carefully, it can still go into the lungs. So, so the feeding tube does not prevent aspiration. You think it would. You think if you bypass the throat, everything would be hunky-dory.
Yeah.
Right, but unfortunately it doesn't, because it doesn't stay down there, and you still have saliva. And then you had raised another question about the nutrition.
Yeah.
So again, it seems like, oh, if you're not eating enough by mouth, we'll just put in a tube. But the tube itself has some risks. It's an anesthesia. It's a procedure. People, especially with dementia, like have no idea what this tube coming out of their belly is, so they might play with it. They might pull at it.
Oh, wow. Okay.
Might get infected.
Yeah.
And actually, a common problem, unfortunately, with feeding tubes is restraints, because especially if people start pulling at it, they get tied down, especially in the hospital, and that's really something we don't want. And you need to be able to process the food. You know, your body needs to be able to digest it, to absorb it, to process it, to get it to the end organs. And so there's actually a lot of data that shows that when patients with advanced dementia number one, they don't need to eat as many calories. And number two, if you feed very slowly and very patiently with something called either recreational feed or comfort feeding, they can maintain the nutrition for a long time, provided nothing else happens.
What is recreational feeding then? How do we do that?
Sure. So recreational feeding kind of recognizes that food is not just a means to an end. It's also an end in itself. The people have value in the taste, the texture, the smell, the feel of food, in the eating environment. You're eating with other people. It's a social activity in our culture. So recreational feed is generally kind of pureed. You pureed food, depending on what the person needs, but you puree the food. You might thicken the liquids. You add a powder so it's thicker, and it's whatever the person likes. Applesauce, ice cream, pureed steak, whatever it might be.
Right. Ruth has always said that she enjoyed eating a lot, and sounds like a nice thing that she can still keep enjoying the taste. And
right.
Sounds like something she would prefer. So sorry I interrupted you, but you're saying so it would be pureed, and then we give it to her the same way you'd feed normally?
In some ways, in that you would be eating by mouth. It's a little bit different because the person giving the food often has to be very patient. I mean, it could take an hour to finish a meal, a plate of pureed food. But that's okay, and if it takes an hour, it takes an hour. And that's a much more enjoyable, natural process, and the patient will guide how much they can handle and how much they don't want, much more naturally than a surgical tube being placed, through a procedure and then food being put in.
Yeah.
And one of the things that sometimes people, sometimes it's a little bit hard for people to understand as people age and as they get sicker, they might not be able to handle as much. They might not need as much, and they might not handle as much. And one of the ways that I sometimes like to think about it is that she's not sick because she's not eating. It's that she's not eating because she's sick.
Okay.
Like a time if you've ever had a bad flu. You just did not feel like eating, and if someone forced food into you, you would feel worse. So I just want you to understand that the feeding tube, a lot of people think that it's kind of, if you can't eat well by mouth, or there's a problem with the swallowing, you could just bypass the stomach and it's equal, but it's not. And in someone like your aunt, it's a little tricky because we have to see how she recovers from the hip fracture to know kind of which path, if this is the beginning of the end or if this is a new normal. We have to see which path she goes on.
Yeah, I mean, based on what I know of my aunt, I think she would prefer this recreational style of eating more, especially if it is her last few months. It's nicer for her to enjoy that experience rather than feel tied down. I don't like the sound of that at all.
Right.
Yeah.
I just declare, not everyone who gets a feeding tube winds up getting restraint, but the use of restraints is much higher in people who have dementia and feeding tubes because they can't comprehend what's going on.
Yeah.
And no one wants to restrain your aunt.
Yeah, of course. Cool. Thank you.
Mm-hmm.
Okay.
Do you have any other questions about feeding tubes or anything else that anyone else has mentioned?
No, I mean, that makes sense, differentiating between the two. I mean, like I said, the other doctor said that we should look at tubes.
Right.
And the speech pathologist had also said that would be a beneficial thing to look at. But I hear now the differences between them, and like I said, like Ruth has said, our aunt likes to eat, likes taste and likes human experiences. So that sounds like something she would prefer.
And it's great. It's great that you have that connection, and that Ruth has the connection to know what's important to her and to honor those wishes. So one other thing I'd like to talk to you about or prepare you for is sometimes patients either with advanced dementia or with hip fractures, and certainly with both, there's an increased risk of something called a pressure ulcer. Okay. Have you heard that term?
No, I just know what ulcers are, but I don't know. No, I'm not familiar with the term.
Okay, so a pressure ulcer is an ulcer or a wound that occurs at a pressure point. So sometimes could be on the elbow, on the hips, on the buttocks. Especially when people have had hip fractures, they can't move around as much as they used to. Right. And when you have dementia, you might not have the recognition that you need to move around. So there's a fairly high risk of your aunt developing a pressure ulcer just because she's had this hip fracture and she has an underlying dementia. Okay. And since we're kind of speaking openly and planning for the future, I want you to know that some people might say or suggest that, if she develops pressure ulcer, it's because her nutrition isn't good, you should put in a feeding tube. Okay. So before someone kind of gives you that misinformation, I want to share with you that feeding tubes have not shown to help people with advanced dementia from Alzheimer's live longer. It does not reduce pressure ulcers, and it doesn't improve healing of existing pressure ulcers. And there's a few reasons for that. One is, even if you put a feeding tube into a person, they still have to be able to absorb and process and digest the tube feeding. And patients with advanced dementia who are not eating purely from the dementia, it doesn't work for that. The other is, when you have a feeding tube, in order to reduce the risk of the food going into the lungs, you have to have the head of the bed up at a fairly high angle. Okay. And whereas you normally would turn and position the person, every 2 hours or so, shift them, put a little pillow so that they're not sitting in one spot all the time. While they're getting that tube feeding, they're basically sitting in that upright position. That puts a lot of pressure on the buttocks. So it actually can increase pressure ulcers because of that extra pressure there. And similarly, when you do the recreational feeding, and we'll go over this with Ruth as well, is she should be sitting upright, she should be paying attention, she shouldn't be lying flat or watching TV, but there are ways to engage her to keep it as safe as you can. Okay. But I wanted to share about the pressure ulcer because that might come down the line, and I don't want you to feel like you missed an opportunity.
But recreational feeding will give her pressure ulcers.
Well, your question is, will recreational feeding give her pressure ulcers?
Right. Just how would it come up if we're doing recreational feeding? Just because of old age and the care? Right,
that's a great question. Right, like if we're doing everything right, how could things go wrong? Right. Because people get sick and people could progress. So depending on how the hip fracture healing goes, how well was she walking before? Was she walking at all?
A little. A little.
Yeah, it's hard to know. Yeah. I would say, recovering from a hip fracture and getting the mobility is hard at any age and with any underlying conditions, but when you add the dementia and you can't remember the instructions, it can be harder. So I wouldn't say that recreational feeding would prevent a pressure ulcer. I think if it's going to happen, it's going to happen. Okay. She's at risk anyway. But if she kind of gets better and she can eat more and she gets better, then she's less likely to have a pressure ulcer. Okay. But the dementia is a risk, the hip fracture is a risk, decreased oral intake is a risk. And you just have to do your best to prevent it, and if it happens, you treat it.
Okay, thank you.
It's clarifying that. No problem. It's hard. It's very. We're so used to medicine fixing everything, right? And sometimes it can't. Yeah. Do you have any other questions or concerns about your aunt?
No, I think it makes sense. It looks like the care we're giving her at the moment is working, and recreational therapeutic feeding sounds like a good solution, considering she hasn't been eating recently, and I don't want her not to eat anything. Right. Although I do understand that you're saying that the fact that she's not eating is a symptom of her the advanced dementia. Right. So that makes a lot of sense.
Right. That's a great way to put it. Yeah. So another thing that I'd like to talk to you about for your aunt is a program called hospice. Are you familiar with hospice?
Yes, I am, but only as a program for patients who have cancer. My aunt doesn't.
No, there's no evidence of cancer. But a lot of people have that perception that hospice is for people with cancer, and it's actually available. It's a Medicare benefit, and a lot of other insurances have it. and it's actually available for anyone with what's called a terminal condition. And there are certain criteria, but basically it could be cancer, end-stage heart failure, end-stage kidney failure, end-stage dementia, and you can qualify for hospice. And hospice is generally a philosophy that says you can't cure or fix my problem, but for the time I have, you can keep me comfortable and supported. And that includes supporting the caregivers, be they family or hired caregivers, and there's visiting nurses and additional services. And it just provides an extra layer of support and help. And I'm not honestly convinced that your aunt is ready at this time, because she was chugging along with her dementia, but now she had this hip fracture thrown in, and that can really, it's a big deal.
Right.
It can really change things. So it's hard to know if she's on the new normal, but not as good, but new normal path, or on the progressive decline that the hip fracture kind of pushed her into. And really time will tell, but I would suggest that we ask the hospice folks to come and do an evaluation, and if we all feel that she's appropriate, then we can do that. If she's not appropriate, then at least you'll know what the services are, so that as things progress, when it's time, you'll know that you can get more help.
So bring them in almost as a referral to sort of check in and...
Right. I think at this point we could do a referral, kind of an informational referral, and then see what they think, and really only time will tell which path your aunt is on, but clearly with your support and Ruth's support, whichever path she's on, she'll be comfortable and supported. And if you have any questions along the way, anytime, let me give you my card.
Yeah, I'd love to be in touch if that's okay.
You can reach out to me. But I think you're doing
much.
I think you're doing a really great time, a really great job at a difficult time.
Thank you. I appreciate it. Thanks for explaining this all.
Any other questions or concerns?
No, it makes a lot of sense. Thank you.
Great. Thank you so much. Take care. Thank you for participating in this part of the course.